Thank you, Dr. Omar. So my presentation is a follow-up, updated analysis of the phase 2 study of MOSUNETUZUMAB in patients with relapsed refractory follicular lymphoma who had received at least 2 prior therapies. This is a multi-center study. Sorry, I think this one. Okay, and Laurie Sen presented the abstract. Laurie Sen is a consultant at British Columbia Cancer Center in Vancouver. So follicular lymphoma, as we know, is the most common indolent subtype of non-Hodgkin's lymphoma, and practically it's an incurable disease, and it has a relapsing remitting course, and these patients at some point have an increased risk of transformation to aggressive lymphoma, and if this happens, it's associated with, as we know, with poor outcomes. Now, MOSUNETUZUMAB is a first-in-class anti-CD20, CD3 T-cell engaging bispecific antibody that redirects T cells to engage and eliminate malignant B-cell lymphomas. It was recently approved by the FDA in the USA and by EMA in Europe for patients with relapsed refractory follicular lymphoma based on this study. So this is a phase 2 study, and the initial presentation, the initial results showed that fixed duration MOSUNETUZUMAB demonstrates a high rate of complete responses and durable responses in patients with relapsed refractory follicular lymphoma who had received at least 2 prior lines of therapy. So this is an updated analysis of the study, and it focuses on patients who had achieved CR at the end of treatment and with a median follow-up of 28 months. The key inclusion criteria were patients who had relapsed refractory follicular lymphoma grade 1 to 3A, who had received at least 2 prior therapies, including an anti-CD20 antibody and an alkylating agent, and it had an ECOG performance status of 0 to 1. Now, MOSUNETUZUMAB was administered in a 21-day cycle with a step-up dosing in cycle 1, as you can see. The step up in cycle 1 was practically to mitigate the risk of cytokine release syndrome. Must emphasize that hospitalization was not required for patients receiving this antibody. So the patients received a fixed duration treatment of 8 cycles. If they achieved CR at 8 cycles, they stopped treatment. If they had stable disease or PR, they continued treatment up to 17 cycles. The primary endpoint was the independent review committee determined CR rate as best response. Toxicity, including CRS, was also included in the analysis. And there was an exploratory analysis looking at the association between total metabolic tumor volume at baseline and clinical efficacy. And this total metabolic tumor volume was derived by PET images at the study entry by using a artificial intelligence-based model. Quite interesting. I think we should get that. So this is the patient disposition at a median of 28 months. 62% of patients completed treatment, while 38% of patients, 38 patients discontinued treatment, mainly due to progressive disease. 59 patients completed 8 cycles of treatment, and most patients had, 82% had received up to 8 cycles of treatment at the in the study. So from the results of the pivotal phase 2 study, we know that the CR rate was 60% with an overall response rate of 80%, and the 24-month duration of CR rate was 63%. In the updated analysis, as I said, we'll be focusing on the CR patients. So of the 54 patients, that corresponds to 60% of patients that achieved CR as best response, 54% of these had achieved CR at end of treatment, while one patient experienced progressive disease in cycle 8, and 4 patients had achieved CR after end of treatment due to a delayed confirmation of bone marrow complete response. So if we look at the baseline characteristics and compare patients with a CR at end of treatment with those, which were 49 patients, with that of patients without a CR at end of treatment, which were 41 patients, we can see that there weren't any significant differences in the ECOG performance status and the Ann Arbor stage. I mean, I think that the differences were mainly that patients who were refractory to their last prior therapy or who were double refractory were actually those who had a higher risk of not responding to the treatment. Here we can see the duration of complete remission, and with the median has not been reached, as you can see, and at 24 months the duration of CR was 65%. If we look at the progression-free survival, again for the 49 patients who had achieved CR at the end of the treatment, the median had not been reached, and the 24-month progression-free survival was 77%. And overall survival, again not reached, and the 24-month overall survival was 100%, quite impressive. Now, this table looks at the duration of response depending on if patients achieved early CR by month 3 of assessment, or with late CR. I mean, the statement we can make is that early CRs and late CRs, there was no difference in median duration of response, progression-free survival, overall survival. So there was no difference if you had a late or early response to treatment. What did matter, as you can see on the right-hand hand, is the patients who had achieved a PR as best response. These patients had a poor outcome. As you can see, the median duration of response was only 4 months in these patients. Now, what about the correlation of best overall response and total metabolic tumor volume? As you can see, so CRs were achieved in patients who had a low and even a high metabolic tumor volume. And the same applied also for PR, stable disease, and progressive disease. So there wasn't any difference. So if you had a high total metabolic tumor volume, you still had a similar chance of achieving CR with those who had a low. Also, if we look at CRS, any grade, it was 44 patients developed CRS. Most, as you can see, was grade 1 or 2. And what they did is they looked at if there was a correlation they were looking at factors that might be associated with the CRS. What they did find is that if you had bone marrow infiltration, the risk of CRS was higher. As you can see here, 33% of patients who had bone marrow infiltration had a higher risk of developing grade 2 or above CRS. While,
1 minute.
Yeah. While patients without bone marrow infiltration had a risk of CRS grade 2 and above of only 13.8%. So in conclusion, fixed duration MOSUNETUZUMAB demonstrated a high CR rate at end of treatment. These responses, as I showed you, were durable, with the majority of these patients remaining event-free at 2 years. And in exploratory analysis, if you had a late or early CR, it didn't make any difference in terms of duration of response benefit. There was no correlation between total metabolic tumor volume at baseline and best overall response. And finally, CRS was predominantly low grade, but it was found that patients who had bone marrow filtration probably had a higher risk of developing CRS grade 2 and above. Thank you.